Um, we'll be discussing another interesting topic, and Dr. Mohit, many of us deal with this kind of situations almost every day in our practice, and we would like to learn from you this time. So, as mentioned in the slide, Dr. Mohit is HOD and Assistant Professor, Mahatma Gandhi Medical College, Jaipur. And I understand you have MD in Pharmacology and MD in Respiratory Medicine. Yeah, that was very interesting to read from your. And he has many publications, which one caught at my attention is the long-term oxygen therapy prescription in India. So that might be something which we may add during our next program in respiratory masterclass probably. That because that is something that we deal with. These patients come to us asking that we cannot manage this. How are we going to? Can you help us with that? And many of us deal with those kind of situations very regularly. So that's one interesting thing I noted in your study. And there are many other publications in which he is involved. Thank you so much, Dr. Mohit, to agree to come here today and to share your knowledge with all of us.
Thank you, ma'am. First of all, happy Diwali and happy New Year to all of you. So we start our today's topic, respiratory symptoms in non-respiratory conditions. So basically, we have 5 cardinal symptoms in respiratory medicine. First is dyspnea, second is chest pain, third is cough, fourth one is expectoration and hemoptysis, and fifth one is the stuttered or wheeze. So we will discuss one of each symptoms one by one. So
Dr. Mohit,
yes,
Dr. Mohit, your slides are not moving, sir.
I think he's moving from my side.
Not for my side. What about others?
No, it's moving, not moving. It is in the not yet in the slideshow mode. It is not in the slideshow. Yeah, now it is moving.
Okay.
Sir, can you make it into the presentation view too?
Sorry?
Can you put it in the presentation view too?
Okay. So okay right now?
We can see all the slides together. So the presentation view would be good.
So I think
just click on view or slideshow, start from the beginning.
Which compromise of qualitative distinct sensation that vary in intensity from person to person. This experience derives from interaction among multiple physiological, psychological, social, and environmental factors, and it induced secondary physiological behavioral response. So in short, it's just a sensation of feeling air hunger or breathlessness. Second thing, orthopnea, in which patient feels breathlessness during lying down position, but not in upright or semi-upright position. Platapnea is opposite of the orthopnea. It's dyspnea induced by assuming the upright position and relieved by recumbency. Tripopnea is when the patient feels breathlessness when the affected side of the chest is in the dependent position. And paroxysmal nocturnal dyspnea is when it occurs during night hours, nocturnal hours, which makes patient aroused from sleep. Patient is gasping for their air, and patient must sit up and stand to catch up. And patient sweat may be profuse, which may be associated with wheeze or not. So there are different terms of dyspnea. So we have to rule out dyspnea, orthopnea, platapnea by asking careful history from the patient. So this is data I take from the palliative medicine from up to date. The patient who came to palliative medicine department for breathlessness, the main patients are from the carcinoma. Either they have carcinoma or they are having in carcinoma stage. Second in HIV patients. Third is lung carcinoma patient. Then heart disease, COPD, renal disease, stroke, amyotrophic lateral sclerosis, and dementia. So these are the different causes of the dyspnea which came to our OPD, especially in palliative medicine OPD, for relief. So there, as we today we are discussing only non-respiratory part. So from cardiac point of view, the cause of dyspnea is.
Dr. Mohit,
yes,
sorry to interrupt. Are you still on the slide where you have mentioned dyspnea, orthopnea, platapnea?
No, ma'am. I just
yeah, that's what we are still seeing. The third slide, that is the paroxysmal nocturnal dyspnea.
I think, ma'am, right?
Yeah, now we have the respiratory, obstructive, restrictive
Okay,
slide.
okay, okay.
Okay.
So ma'am, this is not a slide mode, ma'am, but
You want us to project the slide so that you can just read? You just have to tell what.
because ma'am, when I try to start slideshow, you
Yeah.
guys are not able to view the
See,
slide.
yes.
Myocarditis, like any disease which affects the coronary blood vessels, like myocardial ischemia, myocardial infarction, any valvular disease like tricuspid regurgitation, stenosis, any pericardial disease like pericardial tamponade effusions or pericarditis, any congenital disease like atrial septal defect, tetralogy of Fallot. Next slide, please.
So just a second.
Yes, ma'am.
Yes, sir. You can continue.
So if we divide the causes of dyspnea according to the etiology, so acute etiology mainly because of pulmonary edema or acute left ventricular function. I think we missed one slide, previous slide. Yeah, this slide, yeah. Not this slide. This slide, yes. So already we discussed the cardiac causes of the dyspnea. Right now, there are some hematological causes of dyspnea also, like anemia, carbon monoxide poisoning, methylmaloneynemia, abdominal causes like ascites or GERD with or peptic ulcer disease, metabolic disorders like hypothyroidism or hypothyroidism with Cushing syndrome, psychogenic causes can cause dyspnea like anxiety or panic attacks, neurological disorders like neuromuscular disease like ALS, amyotrophic lateral sclerosis, GBS, Guillain-Barré syndrome, myasthenia, or physiological causes like exercise, deconditioning, or obesity. But there are some uncommon causes also which we encounter during our emergency posting, like trauma, foreign body aspiration, vocal cord dysfunction, hemothorax, tetanus, hepatopulmonary syndrome, angioedema of the tongue. So we have to remember maximum causes of dyspnea, but we have to rule out all these causes by asking careful history and some investigation. We will discuss how to evaluate the patient when the patient comes in dyspnea. Next slide. So according to etiology, we can divide the cause of dyspnea in acute and chronic. Acute causes pulmonary edema or acute left ventricular function, acute left ventricular function. Second, pulmonary hemorrhage, foreign body aspiration or vocal cord dysfunction. In chronic cases, pulmonary thromboembolic disease, pulmonary vascular disease, severe anemia, hemoglobin is less than 5, psychogenic dyspnea, post-intubation tracheal stenosis, left ventricular failure, or renal failure in CKD patients. Next slide. So many patients who come to us in emergency, either they have respiratory causes or in non-respiratory causes, we have seen most patients, they have congestive heart failure. So they are the basic, this is the diagram is showing, we can see patient has cough, crackles, wheeze, blood tinge sputum like a pink frothy sputum with tachypnea, with patient is restlessness, patient is confused, patient is typically orthopnea, means patient is feeling dyspnea during lying down position and it relieves on upright position. Patient is having tachycardia, patient is having dyspnea with fatigue and cyanosis. Next slide. So what is the mechanism of dyspnea in chronic cardiac disease? If we take left ventricular failure or mitral stenosis, there are two mechanisms. First is edema of the tracheobronchial mucosa, and second thing, there is increase in pulmonary venous and capillary pressure. Edema of the tracheobronchial mucosa leads to increased airway resistance, while increase in pulmonary venous pressure leads to interstitial and alveolar edema. Both of these things decrease the lung compliance, which leads to there is large swings in the pleural pressure. which leads us to increased work and energy cost of the breathing. So the cause of cardiac patients, the cause of dyspnea in cardiac patient is increased work and energy because of the increased airway resistance, and there is increase in interstitial and alveolar edema. Next slide. While in chronic kidney disease patient, there is fluid overload because of the hypoalbuminemia or chronic kidney disease, which leads to pulmonary edema, pleural effusion, and lung congestion. Patient who have chronic kidney disease, they have vitamin D deficiency, they have multiple vitamin deficiency, they have abnormal calcium metabolism, they have less albumin. So all this leads to malnutrition, which leads to worsening of the respiratory muscle efficiency. Like erythropoietin is secreted from the kidney, but in CKD patients it lacks. So there is anemia, which also leads to the dyspnea patients. Next slide. While the cause of dyspnea and chronic liver disease, we can divide into three parts. First part is hepatopulmonary syndrome. Second is portopulmonary hypertension. And third is hepatic hydrothorax. What is hepatopulmonary syndrome? Patient is having hepatic disease. Second, in pulmonary, there is a formation of the shunt, which leads to dyspnea, platypnea, resting hypoxemia, progressive cyanosis, and orthodeoxia. What is portopulmonary hypertension? Means patient has portal involvement, which leads to pulmonary arterial hypertension, which leads to increased mean arterial pressure, increased pulmonary vascular resistance, and in the background of the portal hypertension, which leads to the dyspnea. Hepatic hydrothorax, the patient who is having chronic hepatic disease leads to ascites, and there is diffusion of the fluid, ascitic fluid, through the diaphragmatic membrane into the pleural cavity. If it is greater than 500 ml of pleural effusion, right side or left side, it known as hepatic hydrothorax, and because of that passive collapse, patient is having dyspnea. So in different disease, in chronic kidney disease or chronic heart disease or chronic liver disease, the causes of dyspnea is totally different. The causes, the pathology behind the dyspnea is totally different. So we should know if patient comes to us in dyspnea during emergency or during daytime, what is the cause of the patient, what is the cause of dyspnea in this type of the patient. Next slide. So if the patient is a known case of the cirrhosis, so causes of the dyspnea may be pleural effusion, already we discussed, like hepatic hydrothorax. Patient is having pulmonary vascular complication like hepatopulmonary syndrome. Patient is having tense ascites, which can lead to dyspnea. Patient having some immune-mediated lung disease like ILD. There is a very close relationship between primary biliary cirrhosis and interstitial lung disease patient. Patient can have thoracic manifestation of hepatocellular carcinoma, or patient is having inferior vena cava syndrome. So we should know the cause of the dyspnea in cirrhosis, in kidney disease, or in cardiac patients can overlap to each other. Next slide. Cause of dyspnea anemia is inadequate oxygen delivery, which leads to high cardiac output and low peripheral resistance. While in metabolic acidosis or drug-induced metabolic acidosis, there is increase in CO2 production, which leads to increase in demand, increase in ventilation, which leads to dyspnea. So any patient who comes to dyspnea is not a cause, is not a patient of the respiratory part. It can be metabolic part, cardiac part, liver part involvement, or kidney involvement. Next slide. Like some patient is skeletal deformity like kyphoscoliosis, pectus carnicatum, pectus excavatum, sclerosis or kyphosis, or obesity. They have limited chest excursion, which leads to alveolar hypoventilation, which increase the demand, which leads to dyspnea. While in neuromuscular weakness, there is limited chest excursion and there is overload of the respiratory muscles because of the neuromuscular weakness, which leads to alveolar hyperventilation, which leads to increased demand and dyspnea. Next. So these are the some investigations we have to rule out particular cause of to find out the etiology. Like in we first of the any patient comes to us, we have to do chest radiograph. So in chest radiograph, we can diagnose congestive heart failure, like there is bilateral involvement of the Patchy opacities, basically there is hilar opacities bilaterally, there is hilar prominence with some patchy opacities in chest X-ray or in pulmonary hypertension. Second thing we have to do, we are discussing today only the non-respiratory conditions. We have to do some inspiratory and expiratory pressure in PFT test. After that, we can diagnose that there is cause of dyspnea is respiratory muscle weakness. If we do CTPA, computed tomography, pulmonary angiogram, we can rule out the pulmonary embolism. In blood test, like increased WBC count, we can rule out the infection. If the patient hemoglobin is less than 12, we can rule out the anemia. If patient's brain natriuretic peptide is increased, we can find out the cause of maybe heart failure or renal failure is there. If patient's serum creatinine raised, the patient is a case of acute kidney injury or chronic kidney disease. If patient is ABG, arterial blood analysis is showing there is acidosis or alkalosis, we can rule out the metabolic causes of the dyspnea. Next slide. So when we ask the patient, when we ask the history, in history, patient tell us the intensity of the sensation of the dyspnea. If patient is rating, this is called as Borg scale. According to that, we can define the intensity of the breathlessness. If patient has 0 rating, that means patient has nothing, no dyspnea. If patient has rating of 3, patient has slight moderate dyspnea. If patient having very severe dyspnea, we will rate 7. If patient is not able to, is restlessness, then patient has having maximum rating. We give maximum rating for the patient is 10. Next slide. So these are the two scales, modified MRC dyspnea scale and NYHA classification. According to that, we can find out the MMRC grade of the patient. Key patient is having which type of the dyspnea, which grade of the dyspnea in the both types of the scale. So basically in respiratory medicine, we use MMRC dyspnea scale, while cardiologists, they use NYHA classification. In respiratory part, if patient is having breathlessness only on strenuous exercise, then we classify the patient in MMRC grade 0. If patient is having breathlessness during walking up a slightly hill, then we classify the patient in grade 1. If patient is walking slower than of the same age on the ground level, or patient have to stop for breathe when walking on pace on the level, then we classify in grade 2. Then patient is stopped for the breathless because of the breathlessness after walking 100 meters, will classify the patient in MMRC grade 3. If patient is too breathlessness while dressing or undressing on rest, then we will classify the patient in grade 4. NHMI classification is similar, but there is slightly difference. We can see there are 5 grade 5, but in NYHA classification there is only 4 grade. In grade 1 there is no limitation of the physical activity, means ordinary physical activity doesn't cause any breathlessness. In grade NYHA classification 2, there is slight limitation of the physical activity, means patient is comfortable at rest, but ordinary physical activity can lead to breathlessness. In NYHA classification 3, there is marked limitation of the physical activity, but he is comfortable or she is comfortable at rest. And in NYHA classification 4, patient is unable to carry any physical activity. So patient is symptomatic at rest also. Next slide. So these are the qualities of dyspnea and associated disease state. If patient is complaining of chest tightness or constriction, means patient is saying something is clenching, and that cause of other than respiratory causes myocardial ischemia. If patient is taking increased effort or breathing, so there is causes of neuromuscular disease. If patient is having air hunger, he is need to breathe, he's saying I just need to breathe, I have urge to breathe, then patient is having in congestive heart failure or patient is having pulmonary embolism. If patient is suffocating or smothering, then patient maybe have left ventricular failure or pulmonary edema. If patient is just saying I have to take just heavy breathing, I'm not able to take breathe, but it is like there is some weight is put on my chest. So the thing is patient is deconditioning. Basically these patients are of the patient who are obese, the patient who has not a good working lifestyle, So they don't have any disease, but just because of they are not using their respiratory muscles properly, they are feeling breathlessness. Next slide. So these are the red flag signs in dyspnea. Means patient is coming in dyspnea with hypotension, or patient is having tachypnea with respiratory rate is 40 per minute. Patient is in altered sensorium. Patient is confused. On saturation, the SpO2 is less than 90, or patient's PO2 is less than 60. Patients is having cyanosis, stridor is there, or patient has some unstable arrhythmias. Next slide. So the evaluation of patient with chronic dyspnea, if patient is suspecting any chronic dyspnea, first we have to take the detailed history and physical examination. After that, we have to go according to level, which investigation is important. Is the diagnosis evident? Means yes, like patient is having history of asthma or COPD, patient having history of congestive heart failure with paroxysmal nocturnal dyspnea, orthopnea, on auscultation bilateral cramps are there, patient has bilateral pedal edema, patient is hepatic congestion and we can palpate the liver, patient has raised JVP. So this is a case of congestive heart failure. Patient hemoglobin is less than 8, less than 5, or less than 12. Patient is a non-case of anemia, and patient is typically kyphoscoliosis. If the diagnosis is evident, then these are the causes. If not, then we will go on level 2. Level 2 means we have to go to DECO, BNP, brain natriuretic peptide. We have to go for pulmonary function testing, ABG, HRCT test or CTPA, Holter monitoring for cardiac evaluation, or ventilation perfusion scan for pulmonary embolism. If not, if the diagnosis is evident, yes, the possible diagnosis after these investigations, we can rule out pericardial disease, congestive heart failure, valvular heart disease, coronary artery disease, cardiac arrhythmias. In PFTs, there is restriction pattern, there is restrictive lung disease, or in ventilation perfusion scan is before some VQ scan is not normal, then we can rule out the chronic pulmonary embolism. Still we are not able to find out the diagnosis. Then what are the causes? Possible diagnosis: GERD, coronary artery disease, we cannot find out on the echo, we have to do for coronary angiography. Deconditioning of the patient means patient having nothing disease, is just a patient is not using his respiratory muscles, or primary pulmonary hypertension. Still, if we are doing the level 3 investigation, we are not find out any cause of dyspnea. The cause is psychogenic dyspnea. And during COVID eras, we have seen so many patients who came to us with all investigations normal just because of the psychogenic dyspnea. What is psychogenic dyspnea? We will discuss in next slide. Next slide, please. Next slide. This is next slide.
Yes, sir.
This one is the next. I think next slide, please. I think I send you. Previous slide, please. So what is psychogenic dyspnea? Means patient having nothing, and we didn't find out any cause of dyspnea. Patient is just mimicking because of the panic attacks, or patient is having some in corona की डॉक्टर मुझे कोरोना तो नहीं हो गया है, मेरी सांस फूल रही है, just because he is seeing around so many of corona patient, he is having dyspnea. There is no cause of the dyspnea, it's just a psychogenic cause. So the second symptoms is cough. So there is any cough is a reflex. So any reflex, we have efferent, we have center of relay, then we have efferent. So efferent, the receptors not cough receptors not include only respiratory part, but it presents in eardrum or canal, in pharynx, larynx and supralaryngeal area, in esophagus, in pericardium, in stomach also. So the efferent is vagus nerve, which relay their the signal of the cough relays in the medulla oblongata. It is a cough center in medulla, which is modified in the according to cough center in which is present in the cortex. It's modified according to them. Then the efferent is vagus nerve, spinal motor neurons, and phrenic nerve, which contracts the diaphragm, which involves the pleura, and which stimulates the trachea and the lower bronchus. Next slide. So the non-respiratory cause of cough is mediastinal tumor, aortic aneurysm, GERD, foreign body aspiration, left ventricular failure, or pulmonary infarction or pulmonary embolism, pulmonary contusion, or patients who are taking drugs like angiotensin converting enzymes, captopril in enalapril, lisinopril in hypertension patients. Next slide. Some causes because of the advanced cancer, like there is formation of the esophageal respiratory fistula, like the patient who is having CA esophagus, they have there is chances of formation of the fistula. Second is extrinsic or intrinsic airway obstruction, like in mediastinal tumor. Pericardial effusion, there is, as we already discussed, the cough receptor is present on the pericardium also. So any pericardial abnormality can lead to cough also. Next slide. So how to evaluate chronic cough? Chronic cough means the patient is having cough greater than 3 weeks. So first of all, we have to take a good history, good physical examination, asking patient about asthma or allergic rhinitis, which leads to PND or GERD. In GERD, patient typically gives the history of cough increase after the meal, after the oily meal, or if patient tries to sleep after food, patient is having cough, especially during night hours. So if we find out the cause, we have to treat accordingly. If patient is having any drug history of AC inhibitor, we have to rule out that also. After that, if cough resolve, we need to go further. But if still cough persists after taking good history, drug history, and rule out any drug causes, if the cough persists, we have to go for the chest radiograph. If chest radiograph is normal, means there is no parenchymal cause or pleural cause of the cough. If it is abnormal, then we will treat the respiratory cause, or pleural effusion, we have to tap the pleural effusion, or if there is consolidation, we have to treat the pneumonia. Next slide. So if the cough resolve, if still cough persists, we have to check out about the upper airway cough syndrome. Upper airway cough syndrome, maximum we see during winter hours, or patient who is having atopy. These patients, they have typically post-nasal drip, means they have allergic rhinitis or sinusitis. So during night hours, that there is dippling of the nasal discharge into the throat that causes the cough. If patient is having GRD, so then we posted the patient for esophageal pH monitoring. If cough resolved, we have to treat the GRD. If still cough persists, then we will go for the cardiac studies like 2D echo or cardiac angiography to rule out any cardiac causes. If the patient having cardiac disease, then we will treat accordingly. Cough resolved. If still cough persists, then it may cause the causes is psychogenic cough. What is psychogenic cough? We'll discuss in next slide. Next slide, please. So psychogenic cough is already called, we can call it somatic cough syndrome. This is all the second symptoms we can see during COVID hours, during COVID time. And in maximum, the patients who are having somatic cough syndrome, they are children and they have persistent cough. We can see now daily OPDs की patient की मेरा बच्चा इसको खांसी रहती है 24 घंटे खांसी रहती है बट जब ये सोता है तो खांसी खत्म हो जाती है. The thing is, this is somatic cough syndrome. It can precipitate by the post-viral illness, but still there is no cause. So these are some criteria we can classify the patient as psychogenic cough. It decrease or is absent during sleep first. On examination, everything is normal. Like in auscultation, we don't find any cracks or any wheeze or any stridor. Patient has no apparent organic or physiological etiology. Means all the blood investigation is normal. Patient is not malnourished. Patient is having there is no other cause. Patient is not having any brain tumor or any cerebrovascular disorder. It results in prolonged school absenteeism. Like in during Corona time, school was totally, there was no school, online classes are going on. So the maximum patient we see during Corona times because of the prolonged school absenteeism. And finally, it is a diagnosis exclusion. If we rule out all the other causes of the cough, like cardiac cause or respiratory cause or GRD or drug history, after that we can classify the patient as a somatic cough syndrome. Next slide. So these are the neurologic condition with increased cuff reflex sensitivity, like in cerebral disorders, already we discussed, like in medullary space, Budd-Chiari malformation, or there is a space occupying lesion in the cerebellum, or patient is any optica spectrum disorder. Patient has some other cerebellar disorders like autosomal dominant cerebral ataxia, or patient has some vagal neuropathy like we can see in our post-viral infection patient, or patient is experience some irritant exposure like in outdoor air pollution or indoor air pollution, or patient is having chronic condition like asthma, and in some vitamin B12 deficiency we can see increased cough reflex sensitivity. Next slide. Third, uh, cardinal symptoms of respiratory symptoms is expectoration or phlegm or sputum. So the purulent and mucoid, basically the causes behind the pathology behind is purely respiratory, but this patient is having frothy pinkish sputum. The cause is left ventricular failure or pulmonary edema. Most commonly it is cardiogenic pulmonary edema like mitral stenosis or after myocardial infarction. If patient is having blood tinge expectoration, it can be occur in pulmonary embolism, or patient is having some clothing disorder. Next slide. So what is hemoptysis? In our OPD hours or in emergency, already we are confused what is hemoptysis, pseudohemoptysis or hemoptysis. So we can differentiate hemoptysis from pseudohemoptysis by asking clinical history or asking the picture of the sputum, what is expectorate. So hemoptysis is a condition that involves spitting or coughing of blood along with sputum that originate in the lungs or bronchial tubes, like it is the cause of the respiratory causes. While pseudohemoptysis is the blood from source other than bronchial pulmonary system, like pharynx, oral cavity, dental infections. Origin is below vocal cords, and in pseudohemoptysis is above vocal cord. May be mixed with sputum, but pseudohemoptysis never mixed with the sputum. Persistent in patient is having cardiac or respiratory disease, patient persists as blood in sputum, but in pseudohemoptysis, there is no persistence. Chest X-ray is abnormal hemoptysis, while in pseudohemoptysis, this is absolutely normal. Next slide. Like hematemesis, so many patients who comes to us after coughing, they omit all the food like material, but they have some उनके खांसी की वजह से खून आया था. So we have to rule out hemoptysis and hematemesis also. So hemoptysis is already we discussed coughing up of blood, but hematemesis is the vomiting up of the blood. Causes in hemoptysis is respiratory or pulmonary embolism, while hematemesis the causes are GIT problems, or patient is taking any painkillers like NCID, or patient is having some chronic liver disease, or patient is consuming alcohol. So appearance, it is foamy and bright red color, while hematemesis is coffee ground or bright red in color. Diagnosis is on the basis of the physical examination, chest X-ray, CT, and bronchoscopy. In hematemesis, we can do the endoscopy, gastroduodenoscopy, esophagoscopy, and asking the patient clinical history, classical history of GRD or peptic ulcer disease. Treatment, like we treat the disease, treat the cause of the hemoptysis, and like hematemesis, the cause is esophageal varices or GRD or peptic ulcer disease. We'll use the proton pump inhibitor or injection sclerotherapy or endoscopic band ligation. Next. So these are the causes of the airway disease which cause the hemoptysis. These are the pulmonary parenchymal disease. Second, next slide, please. What pulmonary vascular disease also leads to hemoptysis, like heart failure patients, like pink frothy sputum because of the pulmonary edema, mitral stenosis, pulmonary atrial malformation, pulmonary embolism. Breathing disorders also can lead to hemoptysis, like patient is having anticoagulant or patient is taking anticoagulant or antiplatelet medications, like in our cardiac patients or kidney patients. Patient is having disseminated intravascular coagulation. Patient is having some platelet dysfunction because of renal failure or some autosomal dominant recessive disorders. Patient is having von Willebrand disease or some external blunting or penetrating trauma, or patient having any airway stent because of the some airway malignancy. Patient is going is iatrogenic hemoptysis, like patient is undergoing any transbronchial biopsy or bronchoscopic biopsy or any bronchoscopic procedure, or patient undergo any tracheal intubation, or patient is undergo any CT guided lung biopsies. Next slide. Some miscellaneous causes, like patient is consuming cocaine or patient is having on bevacizumab treatment. It's a anti-VEGF treatment using in many CA carcinoma of breast or other carcinoma patients. Patient is taking, patient is having amyloidosis. Patient is having any rheumatic disease like good pasture disease. Patient is having some vasculitis like granulomatous with polyangiitis and other vasculitis. So any vascular pathologies like middle vasculitis, especially these patients having kidney problem, they having ENT problem, they have having respiratory involvement. So because of the multi involvement, they vascular involvement or multiple disease, multiple system involvement, they are having hemoptysis. APLA patients or SLE patients. Next slide. So how to evaluate the non-massive hemoptysis? We have to ask the history and physical examination. These are the main pillars. Diagnose any disease. We have to rule out pseudohemoptysis and hematemesis. Then we have undergo chest radiograph. If the patient chest radiograph is normal, then we have to rule out other disease. If abnormal, then patient is having consolidation. We have to start the antibiotics. If patient is having mass, then we go for the chest CT. After that, we will do bronchoscopy. If patient is have other parenchymal disease like ILD or any other disorder like good posture syndrome, we have to do the chest CT, HRCT. Next slide. So already we discussed the non-life-threatening hemoptysis. So after the how to evaluate, then this is the gross evaluation method. First of all, we have to rule out the patient is not having any life-threatening hemoptysis. What is life-threatening hemoptysis? If the bleeding is greater than 150 ml in last 24 hours, or it is 100 ml per hour, along with or without respiratory distress, or a patient is having hypoxemia in ABG or hypercapnia, and patient is hypotensive, then we will do the chest radiograph. If it is normal, then we have to find out the cause of the pseudohemoptysis. Either there is a nasal bleed, or patient is having oral telangiectasia or nasal telangiectasia. If patient is after vomiting, like it is not the hemoptysis, if patient hematotemesis, so bleeding may be coming from upper respiratory tract or GIC source. So we have to evaluate the nasopharynx or ENT or GI surgeon. If no, we have to find out the risk factor for the lung malignancy or pulmonary embolism. We can box A and B. If patient is having lung malignancy risk factor, like patient is a smoker, or patient is having biomass exposure, or patient is a history of COPD or IPF, patient has some asbestos exposure. These are the risk factor for lung malignancy. And risk factor for pulmonary embolism are patient has history of venous thromboembolism, patient has history of deep venous thrombosis, patient is immobilized and having history of surgery in prior 4 weeks, or patient is a non-case of some malignancy, and patient is pregnant also, or patient is using oral contraceptives. These are the risk factor for the pulmonary embolism. Next slide. If there is no yes, if the patient is having risk factor of the pulmonary embolism malignancy, then we will treat that part. If no, then we have to ask about the upper respiratory tract infection. If yes, then we have to observe for recurrence. There is no recurrence, there is no need of for any further workup is needed. If patient has recurrent hemoptysis, then we will go for the investigations like coagulation profile to rule out any coagulative disorders. We will go for the creatinine BUN to rule out the kidney disorders. We rule out the liver causes of the any antiplatelet dysfunction is not there. We have to rule out the D dimer. If the D dimer is greater than 500, then we can rule out the pulmonary embolism. If there is raised brain natriuretic peptide or ECG is showing some abnormal ways, then we can suspect the heart failure. If these are the abnormal imaging findings present, next slide, then we will do we and classify the patient as heart failure or pulmonary embolism, or patient has some vascular lesion also. If no, then we have to work up of the persistent or recurrence of the hemoptysis. Next slide. The fourth symptom is chest pain. Chest pain, just these are the various causes of the chest pain, like muscle strain, costochondral symptoms like costochondritis, Teat syndrome, Sternalis syndrome, xiphoidalgia, spontaneous sternoclavicular subluxation, means anything which is present on our precordium, like muscular part. We have ribs, which consist of cartilage part, and the rib part, which is consist of the bony part. We have xiphoid, any pain related to the sternum, involvement of sternoclavicular joint. Patient is having lower rib pain syndrome, or patient having posterior chest wall syndrome, which is because of the herniated thoracic disc, or patient is having osteoarthritis of the sternoclavicular joint. Means chest pain can be due to muscle pain, bony pain, sternal pain, sternoclavicular involvement, any involvement, any can cause chest pain. Next slide. So on the basis of the radiation of the pain or involvement of the part, we can rule out the causes, some causes of the chest pain. If patient is having shoulder pain, chest tightness, patient is which is radiating to the left arm, it is a typical cardiac originated pain. Or if the patient's pain is only involve only the shoulder, it can because of the aortic dissection, or there is some diaphragmatic inflammation because of the C3, C4, C5 nerve. It is radiating in nature. If patient is having right shoulder pain, then patient has some diaphragmatic inflammation, basically right dome of the diaphragm, or patient is having some thoracic outlet syndrome. If patient is a typical mid-sternal pain, it can be any cause, like in acute pericarditis, acute coronary syndrome, spontaneous pneumothorax, esophageal disorder like GRD associated with the abdominal pain. So according to involvement of the body part, or the chest pain is related to which shoulder, right or left, or either it is related to the left arm or not, or it is just substernal or parasternal or epigastric burning pain, we can rule out the causes of the chest pain. Next slide. So we can classify according to the system wise. Cardiac pain, a cardiac origin, the causes myocardial ischemia or pericarditis. In vascular causes, we can have acute aortic syndrome or pulmonary embolism. So in cardiac, myocardial ischemic pain is typical retrosternal, radiating to the neck, jaw, shoulder, or arms, sometimes epigastric. If we do the auscultation part, then there is S4 is there, or we can heard some murmur also. In pericarditis, it is relieved by sitting up and leaning forward. So if patient is having some, it's called Momden position also. The typical location is retrosternal or toward cardiac apex, which leads to the pain can be related to the left shoulder. While in vascular cause like acute aortic syndrome, there is sudden onset of the unrelating pain, which is like tearing or ripping knife-like pain. If something is stabbing in the chest, which associated with the hypertension or underlying connective tissue disorders, or any murmur of the aortic insufficiency can be there. Next slide. GRD patient, like GIT causes reflux, esophageal reflux or esophageal spasm, peptic ulcer or gallbladder disease. They have increased by postprandial recumbency, which is related by the antacids, can mimic angina. But peptic ulcer, there are two types of ulcer, duodenal ulcers and gastric ulcers. Some ulcers relieved by the food or antacids. Neuromuscular causes like costochondritis. In ribs, we have called there is junction of the cartilage and the rib bony part, which is called due to then some viral infections. After viral infection like Epstein-Barr, Coxsackie virus, or herpes virus, there is inflammation of the costochondral junctions, which leads to costochondritis. We can see that joint is swollen, tender and warm over joint, which can be increase the pressure if we localized, or if we put pressure on the localized site, the patient is like if the chest pain is increased. If we relieve the pressure, the intensity of the chest pain is decreased. So we can rule out costochondritis pain. Patient is having typical history of viral infection, fever. The joint costochondral junction is swollen, tender. If patient is something trauma, the patient is giving typical history of the trauma, which can increase by the movement or palpation. Patient can having psychological cause of the chest pain also, like in panic attacks on patient having depression, they can also complain the chest pain. Next slide. So any patient who comes to us, we have to classify or triage the patient according to the disease, because there is many maximum patient who comes to us, either they are malingering during night hours or they having GRD, especially in young group patients. But in old age group, we have more chances of ischemic heart disease, aortic dissection if the patient is having typical history of hypertension or pulmonary embolus. So we have to ask some causes. We have to ask some answers to the questions to the patient. Could the chest discomfort be due to acute potential life-threatening condition that needs urgent evaluation management? Then we can rule out these are the causes, and we can divide. We can do the chest X-ray and ECG, and we can rule out the maximum causes. If not, could the discomfort is due to chronic condition likely to lead to serious complication? That means patient is having stable angina or aortic stenosis or pulmonary hypertension. Next slide, please. If not, could the discomfort be due to acute condition that warrants specific treatment, like patient is having fever or chest pain, recent onset, and patient is having some viral infection, or patient is having corona. We have seen so many patients who is having pericarditis because of the corona, or patient having pleural effusion which leads to pleuritis, or patient is having some skin lesions uh, that warrant specific treatment, like in pericarditis we have to give NSAIDs, aspirin, or steroids. In pneumonia we have to give the antibiotics. And in pleuritis we have to tap out the pleural effusion. In herpes zoster we have to start acyclovir or ganciclovir. If not, could the discomfort due to another treatable chronic conditions like GRD, esophageal spasm, peptic ulcer disease, like cervical disease, cervical disc disease can lead to chest pain because of especially C3, C4, C5, if our patient is having costochondritis. So according to that, in emergency, we have to triage the patient according after asking proper history or do the minimal investigations. Next slide. So the probability of ischemia is increased if the chest pain is central, which is squeezing and gripping, like patient is complaining of chest tightness or chest heaviness, or it is related, stress related or exhaustion related, and is typically retroesternal in origin. So there are high probability of ischemia. If the patient typically complaining of thoracic chest pain, like the chest pain which is increase on in deep inspiration, that is pleuritic. Patient is having some positional, like patient is taking left side or left side recumbent position, or patient is having sharp pain, then there is low probability of the ischemia. Next slide. So if we divide according to age group, the causes of the chest pain, if we find out the younger age group, the maximum 50, up to 50%, the cause of chest pain is the non-specific chest. But in 45 to 64 years of age group, the second cause is coronary atherosclerosis. But if patient is greater than 65 years age of group, the causes of non-specific chest pain still higher, but the chances of the coronary artery disease or acute myocardial infarction is increased after 65 years age group. Next. So if patient comes to us in chest pain, we have to take detailed history and physical examination, go for chest X-ray or ECG. In ECG, if we found a ST elevated MI or diffuse ST elevated pericarditis or ST depression or mutive inversions are there, or patient is non-diagnostic or normal ECGs are there. So we have to repeat ECG if the patient's troponin T is positive, or patient is having some neurarrhythmias. So we have to follow the particular, we have to follow the treatment arrhythmia guidelines. And the patient is having some ECG changes, we will treat according to their etiology, or according to their, if ST elevated MI is there, then we have to start aspirin, or we have to if patient is having some hypotension, we have to start streptokinase, we have to give thrombolytic also. Next slide. Another symptoms is stridor wheeze. So there are so many students, they ask, sir, what is the difference between stridor and wheeze? So stridor is a louder, constant pitch which is sound over central airways like trachea, around trachea, over the trachea. While wheezing is a musical sound, it primarily produced during expiration. So first off, we have to rule out what is stridor and wheeze. If noise breathing is there, both are the causes. And according to that, we will classify the patient and treat the patient. Again, stridor is divided into three parts: inspiratory stridor, biphasic stridor, and expiratory stridor. If patient is having inspiratory stridor, means we put our stethoscope on the trachea. During inspiration, we are seeing some noisy breathing on the trachea. Then causes is goiter, extraluminal, or retropharyngeal abscess, or if intraluminal causes can be malignancy or foreign body. So these are the some intraluminal cause are the some emergency. Otherwise, goiter is not an emergency. But retropharyngeal abscess is the emergency. Patient is having some other symptoms like hypotension or swelling is there. Patient have sign of septicemia is there, or patient and some anaphylactic shock is there. Biphasic means patient is having stridor during inspiration and expiration both. It can also present in vocal cord dysfunction or in malignancy, or patient having vascular link, like there is aberrant subclavian artery or there is aortic aneurysm which crossing the external or recurrent laryngeal nerve or external laryngeal nerve, or patient is having intraluminal body. Expiratory causes like mediastinal masses, or patient has some vascular ring or aneurysm, or patient is having foreign body. While these is mostly present in asthma, COPD patients, or patient is having pulmonary edema, patient is having bronchitis, or patient has foreign body, but the small foreign body. This is monophonic wheeze, which is present. Wheeze can be present with the foreign body situated in the bronchus part. So we have to rule out stridor and wheeze. Next slide. Some deep neck infection, they can also present with stridor and wheeze, like anterior cervical infections or peritonsillar infection, retropharyngeal is abscess. They can also present in the with the stridor with some respiratory problems, just because they have a deep cervical fascia, which have connection to the trachea part also, which have connection to the vertebral part also. So these infections, either it is pretracheal space or prevertebral space, or there is superficial space. Any infection of these part can lead to stridor, along with dyspnea, along with throat pain, along with anaphylactic shock. So before going to find out the cause, the patient is having some respiratory problem, we have to also know that there are some non-respiratory causes of stridor also, or dyspnea also, or cough also, especially during, because these all deep neck infections are the emergency conditions. They need attention, specific attention. So during that time, we have to ask the particular ENT department, or we have to go for the emergency tracheostomy, because the typical symptoms, like patient is having fever or dysphagia, chest pain, throat pain, neck swelling is there. We have to think first of all deep neck infections if the chest X-ray and other chest X-ray is not normal. Next slide. Some neurological disease can also lead to respiratory failure, like peripheral neuropathies, like Guillain-Barré syndrome, critical illness polyneuropathy, or a patient is having lymphoma, patient is having vasculitis, disorder of the neuromuscular junctions like myasthenia gravis, botulism or hypermagnesemia, or patient is having tick paralysis or snake bite, or patient is having disorder of the muscles like hypokalemia, electrolyte disbalance, hypokalemia, hypocalcemia, and hypomagnesemia. Patient is a history of the trauma which leads to rhabdomyolysis, or patient is having lymphoma, or patient is taking any chemotherapeutic drug agents. So these are the causes which leads to dyspnea, cough, respiratory disorders, respiratory dyspnea, feeling of air hunger. So these are the causes which related to the dyspnea other than the respiratory symptoms, respiratory disorders. Next slide. So basically what happens in neurological patients, they have no control over breathing. They have dysfunctional control of breathing. They have altered respiratory muscle dysfunction. They have altered respiratory mechanics, and they have some sleep-related breathing disturbance. Next slide. So in control of breathing, there is abnormality in the afferent information from the diseased respiratory muscles. Because of the abnormal lung and chest wall mechanism or upper neuron dysfunction leads to decreased ventilatory response to the hypoxic and hypercapnic challenge. Because in normal pain, what we will do when we feel hypoxemia, we will hyperventilate and we can wash out the CO2, we can inhale. But the patient who's having neuromuscular disorder patients, they don't have such a mechanism. They respond to the hypoxic or hypercapnic challenge because of the involvement of the central or peripheral origin. Next slide. They have respiratory muscle dysfunction, which leads to fatigue or dyspnea, which leads to impaired control of the secretions, which leads to aspiration pneumonia, and patient is having cough and the dyspnea. Patient has chances of recurrent lower respiratory infections, will lead to respiratory failure, and patient can develop pulmonary hypertension, cor pulmonale. The thing is, these are the non-respiratory causes. The patient is having some neuromuscular disorders and patient is having respiratory symptoms. Next slide. In altered respiratory mechanism, the defective central drive, the patient is taking rapid shallow breathing pattern and there is decreased ventilatory response to the hypoxic and hypercapnic challenges. Along with there is atelectasis of the also, which leads to decreased vital capacity of lung, decreased inspiratory capacity, decreased functional residual capacity, decreased expiratory reserve volume. Next slide. And they have sleep related breathing disturbance also, like there is increase in upper airway resistant. Patient is having hypoventilation, especially during REM sleep. Patient decline in the chemosensitive to the blood gas changes, like in normal patients, if there is some changes in blood, like patient is having PCO2 is raised, patient can hyperventilate and CO2 washout is there. But in patient who is having neuromuscular disorder, they don't have the similar mechanism. Or patient is having some, a patient is taking some CSV breathing also. So these patients are more prone for the central sleep apnea type, or patient is having some other sleep related breathing disturbance. Next slide. These are the some other disease. Obesity. In obesity, we find patient comes to us, many obese patients, they comes to us with dyspnea. We didn't find any X-ray is normal, echo is normal. The cause is in obesity, there is VQ mismatch, which leads to hypoxemia. Patient is having obstructive sleep apnea. Patient is having increased work of breathing because of the excessive weight on precordium, which leads to hypoventilation. And in patient has some leptin resistant, which leads to decreased ventilatory drive. All this leads to hypoxemia and hypercapnia. So the cause of the dyspnea in this patient, in obese patient, is not because of the lung or cardiac disorder, it's just because of their unhealthy lifestyle. Next slide. Some patient who comes to us after transplant, maximum in tertiary care centers, the liver transplant patient, bone marrow transplant patients or kidney transplant patients, they have some other respiratory involvement is there, but not because of the respiratory illness. There is involvement because of the stem cell transplant, or just because of the side effects of the liver transplant, or complication of the liver transplant, heart transplant, or kidney transplant. Like a patient can develop bronchiolitis obliterans syndrome, or hepatopulmonary syndrome, or diffuse alveolar hemorrhage because of the hyperimmunity, or patient is taking some drugs because or patient is having graft versus host disease, which can lead to pulmonary complication in transplant patients. Next slide. Drug induced, the We can see so many patients, they don't have any chest X abnormality or 2D is normal, but we ask the drug history, then the patient is consuming captopril, enalapril, or patient is some taking aspirin, or patient is taking some immunomodulators, or patient is having some taking cancer chemotherapy. So these are the side effects because of the especially cough or bronchospasm, vasculitis or diffuse alveolar hemorrhage, like aspirin, azathioprine can lead to vasculitic disorders, or patient is having pulmonary edema because of the consumption of the drugs like interferon, or patient is on propylthiouracil, propofol, or patient is taking some tricyclic antidepressants or neuroleptics. So before we have to rule out the drug-induced causes of the respiratory symptoms. Next slide. So many patients come to us with connective tissue disorders like systemic sclerosis, mixed connective tissue disorder, dermatomyositis, systemic lupus erythematosus, Sjogren syndrome, or rheumatic arthritis. They have involvement of lung, but just because of the connective tissue disorders. They don't have primary lung disorders, but just because they have connective tissue disorders, there is involvement of the respiratory symptoms, respiratory involvement, parenchymal involvement, or pleural involvement, or vascular involvement, which leads to respiratory symptoms in connective tissue disorder patients. Next slide. Acute chest syndrome in hematological abnormalities like sickle cell anemia. We can find out the patient is having acute chest syndrome. If the criteria is if patient is having some alveolar consolidation, but there is no collapse, at least involvement of there is lung segment, is accompanied by chest pain, fever, tachypnea, wheezing, or cough in sickle cell disease patients. The cause is fat embolism, chlamydia, mycoplasma pneumonia, some bacterial infections, or some miscellaneous infection can lead to acute chest syndrome. Next slide. The cause is in normal patient, no normal hemoglobin is there. The probability of the normal hemoglobin to block the artery is very minimal. But abnormal hemoglobin, just like in sickle cell anemia, it produces blockage of the artery, endothelial damage, which leads to hypercoagulable state and venous stasis, which leads to pulmonary embolism. And there is injury to the vascular endothelium also, which leads to vaso-occlusion, which causes acute chest syndrome. And there is also occlusion of the blood supply to the bone, especially around hip joint, but it can ribs also involvement is there, which leads to acute chest syndrome because of the abnormal sickle cell hemoglobin leads to hypercoagulable state, which cause the chest pain like symptoms. Next slide. So after the respiratory breathlessness, cough, they can also preceded by the transfusion. After blood transfusion also, there are some reactions like acute hemolytic transfusion reaction. Patient can present with the breathlessness, hypotension, anaphylactic reactions, transfusion-related acute lung injury. The patient most commonly comes to us after blood transfusion, or in OPD or in IPD patients, we can see TRALI or TACO. TRALI is transfusion-related acute lung injury, and TACO is transfusion-associated circulatory overload. The patient typically gives the history of blood transfusion. After blood transfusion, they feel respiratory distress. If patient is coming with hypotension, with abnormal chest radiograph, hypoxemia, then there is the onset is less than 6 hours, then patient is classified into the TRALI. If patient is having respiratory distress and auscultation, there are rails with abnormal chest radiography, hypoxemia, with raised brain nutrient peptide or anti-proBNP, then patient is classified into the TECO. Some bacterial infection after transfusion can lead to the respiratory illness. Next slide. So we have to classify the patient in TRALI or TACO. So if fever is maybe present in TRALI, but in TACO the temperature is same. Blood pressure, hypotension in TRALI, but in TACO some patient can be present with hypertension. Acute dyspnea present in both. Neck vein is enlarged or engorged in taco, but not in trali. Chest radiograph, bilateral infiltrates which may be diffused in both. Ejection fraction on TD echo is normal in trali, but ejection fraction decrease in taco. Pulmonary arterial occlusion pressure is normal in trali, but in cardiac overload, it is greater than 18 mg. If patient is having pleural effusion after pulmonary edema, in trali is typically exudative because it is because of the immune mechanism, while in transudate, because it is the cardiac overload, it is transudative. So according to that, after clinical examination and some investigation, we can rule out trali and taco. And after that, we can treat the patient on the basis of the diagnosis. In trali, we have to give the symptomatic treatment, while in taco, we have to start the anti-diuretic therapy, or we have to give some cardiac, we have to do some cardiac evaluation, or we have to start some cardiac modality. Next slide. Thank you.
Thank you, Dr. Mohit. So many areas were covered. So I think we need a second go through for the slides to get the details later.
Ma'am, you are not audible, ma'am.
Can you hear me now?
Ma'am, can you speak a little louder, ma'am?
Yeah. So I was just telling there was a lot of information and we need long time to process everything. Thank you for covering all the aspects in detail, starting from the classification and covering all the reasons and the management and everything possible under that topic. Thank you so much. And we have 5 more minutes to take up a few questions if there are any. Are there any questions? You can either type it in the chat or you can ask Dr. Mohit.
Good evening, ma'am. Can I ask a question?
Yes, ma'am. Please go ahead.
I just wanted to know, sir, most of the time in COPD patients, we do use a tablet called Broclear or Pulmoclear, which is a combination of acetylcysteine and ethylboflin. But you told that acetylcysteine can cause bronchospasm or cough. So are we not supposed to use in COPD patients?
The thing is, according, we see the guidelines, gold guidelines for the COPD patients. In acute exacerbation or in diagnosed patients with COPD, there is no role of any mucolytic or any deriphyllin, methyl derivatives like deriphyllin or theophylline or acebrophylline. So there is no use of mucolytic and methyl derivatives in COPD patients. Either patients comes in acute exacerbation or patient is having stable COPD.
When do we use, sir? When we do use acetylcysteine?
There
And
is
does
no
it
guidelines clear cut say no. We are not supposed to use if the patient is having pure COPD, means patient is not having any bronchiectasis, or patient is not there is some patient is not able to expectorate. In these type of condition, we can use the mucolytic agent just to expectorate the excessive secretions of the which is present in the lung. Otherwise, there is no role of N-acetylcysteine, Mucinex or Acinetc. There is no role of methyl derivatives. Some studies saying there is role of methyl derivatives, like methyl derivatives improve the performance of the diaphragm. So we can use the deriphyllin, but according to gold guidelines, there is no role of deriphyllin and N-acetylcysteine in acute exacerbation patient in COPD.
but does it cause bronchospasm, sir?
N-acetylcysteine can cause bronchospasm if we are giving through the inhalational route.
What about tablets, sir?
Sorry?
Tablets in the tablet form?
In no tablet form, no. Because the tablet goes to the GIT first, after then first pass metabolism, it circulates in the blood. So bronchospasm, anything which can cause bronchospasm, acute condition is inhalational through the inhalational route, like irritant gas, any chemical. If we inhale that chemical, if we inhale the outdoor pollution, we can get the bronchospasm. So inhalational therapy through N-acetylcysteine can cause bronchospasm, but not the tablet form.
Okay, sir. Thank you, sir.
Thank you, Dr. Mohit. I think, and these are the medications which is very commonly prescribed when we get patients referred, like especially the Mucinex as
Yes,
well as the
yes.
Daraprim for the acute exercise. Yes, Dr. Ramesh Kumar, please.
Yes, why patient is expired in LVF if he is sleeping within 5 minutes. If he sleeps here, then he expired within 5 minutes in LVF. Why?
Sorry, sir. Can you speak a little louder, sir?
Why patient is expired within 5 minutes in LVF if he is sleeping?
If
In
he's
sleeping
sleeping, yes, sir.
position.
Yes, sir. Yes,
Yes.
sir. Yes, sir. The maximum, the data says the patient who's having left ventricular failure, they have central sleep apnea or they have sleep apnea. Either it is obstructive or central sleep apnea. These patients are more prone for the cardiac arrhythmias also. If we find out the cause of the disease is cardiac arrhythmia or sudden cardiac death, but if we find out the history to the spouse, patient is taking snoring habit, or patient is obese or not, patient blood pressure is normal or not. If we take out the criteria like stop band criteria for obstructive sleep apnea, or if we did the sleep any sleep related breathing disabnormality, like patient is having paroxysmal nocturnal dyspnea, especially during night hours, because night hours they have more sympathetic stimulation during night hours as compared to day hours. Second thing, sympathetic stimulation more during sleep time as compared to awakening time. So sympathetic overstimulation, sleeping related breathing disorders, cardiac arrhythmias, these are the main causes of the death in patients who are having left ventricular failure.
Thank you. I hope that is clear.
Sir, आप please unmute, sir.
So can you unmute and speak?
Sir, I am speaking specifically for LVF. A patient is expired within 5 minutes if he sleeps in sleeping position. Yes.
If he sleeps in,
If patient is kept in sleeping position, then he expired within 5 minutes.
so the cause of then the cause is aspiration pneumonia is also there. The cause is arrhythmias is there. So sir, the
But no,
cause.
but every patient is expired within 5 minutes if he is
No, sir.
kept
No,
in
sir.
sleeping position.
We are treating so many patients, cardiac patient in our ICU, sir. They are doing good, sir.
Oh.
And the cause, the thing is, I don't know, sir, what you are asking specifically.
Yes.
I don't know, sir, what you want to say, sir. Literally, sir, because the cause of death is most commonly, according to American Heart Association, the most common cause of death or etiology in congestive cardiac failure patient is cardiac arrhythmia, sir. The patient is having under cardiac arrhythmia, the chances of death is most.
Okay, sir. Okay. Thank you, sir.
Any other one last question? It's already 8:15, but we can take one more quick question. Yes, Dr. Sheila, please.
Sir, sometimes we can see there's an overlap between asthma, COPD, and GERD symptoms. Not COPD, but mostly it's in cough-induced asthma and GERD. So what happens is it's a cycle. They never come out of a cycle, because when you give beta agonist and steroids, the cough, the GERD gets aggravated, and when you try to treat the GERD, then how do you manage it? It becomes so difficult, though patients who are overlapping of cough-induced asthma and GERD, when they have these overlapping symptoms. It's very difficult to treat such patients.
Genuine question, typically genuine question. COPD, asthma, GERD, three different etiologies. COPD, in COPD, steroid is only indicated during acute exacerbation. Acute exacerbation means patient saturation is less than 90. Patient is having persistent wheeze or rhonchi. Patient is having acute exacerbation. So the treatment of stable COPD is not steroid. We have to give MDA therapy or DPA therapy, deep patient, rotacaps or meter dose inhalers, or inhalational therapy, patient who can do the MDI and DPA. So there is no indication of steroid in COPD patients, stable COPD patients. In acute exacerbation, the indications is only for the 5 days, maximum for the 5 days. Second thing, in asthma patient, the cause of acute exacerbation asthma is GRD also. And we can give steroids in acute exacerbation up to 14 days, not more than 14 days, because after 14 days, there is hypothalamic pituitary adrenal suppression of the hypothalamic pituitary adrenal axis is there. So in asthma patient, we have to give steroid only for the 14 days, not for the chronic management. Neither in COPD, neither in asthma patients. We have to treat both the disease, because if we see the embryology of the GIT symptoms and respiratory symptoms, they originate from the same laryngotracheal bud. So any disease which affects the GIT, the chances of probability of the respiratory disease is also there. So GRD can precipitate asthma. Asthma, because of the excessive coughing, there is looseness of the lower esophageal sphincter is there. It can lead to GRD. So patient is having both the complaints, so we have to treat both the disease, but we have to find out which disease comes first. If patient is having asthma, we have to asthma along with GRD. But if patient's asthma is controlled, then we have to counsel the patient for healthy lifestyle, stop drinking tea, alcohol or coffee or spicy food. Patient have to walk after ingestion of the food, especially during night hours. If patient is still having GRD, he has to sleep a 30-degree elevation after putting 2 pillows below the neck. So we have to do some counseling also of the patient. We have to treat drug treatment is also there. We have to do the counsel the patient also.
Thank you, sir.
Thank you so much, Dr. Mohit, for, the answers were very clear to the questions, to the point. Thank you so much for taking up questions. There can be more questions which they might ask in the WhatsApp group. If there are questions, we'll forward that to you. Please help us by answering those questions.
Definitely. Thank you.
Thank you so much.